If we can begin tonight's webinar with an acknowledgement to country, if we can acknowledge the traditional owners of the lands on which we meet and pay our respect to their elders past, present and emerging. My name is Liam Caffrey and I'm the facilitator for this evening. So this evening's webinar will be made up of a presentation by our guest speaker, Dr. Ben Jonker, and we will follow his presentation with a discussion with our panellists. So our panellists this evening are Kath Meredith, Peter Goff, and Shane Fane. If you have any questions or would like to make a comment, at the bottom of the Zoom screen, there's a floating menu. So if you hover your mouse over the bottom of the screen, you'll bring up that menu and you'll see a Q&A. So if you click on that Q&A, you'll be able to enter a question and we'll be able to see that and include that as part of the panel discussion. So I'd like to introduce our guest speaker now. Our guest speaker is Dr. Ben Jonker. Dr. Jonker is a neurosurgeon with an interest in conditions such as trigeminal neuralgia that are treated with stereotactic and functional neurosurgery. He works at St Vincent's public and private hospitals at Royal Prince Alfred Hospital in Sydney. He has a keen interest in technology and has been at the forefront of the introduction of novel surgical procedures into clinical practice in Australia. Ben has a master's degree in epidemiology, which assists him in applying the best available evidence to treat a patient's problems. Ben is a member of the Trigeminal Neuralgia Association of Australia Medical Advisory Board. And interestingly, Ben has a perfect 5-star Google review rating, indicating his empathy, compassion, and rapport with his patients. Ben is presenting this evening on how to choose the right surgery. So I'll pass over to Ben now. Thanks.
Thank you very much, Liam. I'll just share my screen and bring up the presentation. And thank you to the Trigeminal Neuralgia Association for inviting me to give this talk. You know, there's a lot that we could talk about, and are you seeing my screen now? That look okay? Hopefully it does.
Yeah, that's good. Thanks, Ben.
Excellent. So there's a lot that we could talk about, and but I'm going to try and keep it to the sort of 25-minute mark, and then we'll have a chance for a bit of discussion. So this seminar is on which procedure should I have for trigeminal neuralgia. So look, I think that in order to sort of talk about that, it's important to build a bit of background as to what's going on when somebody has trigeminal neuralgia. So as I'm sure most of you will know, the trigeminal nerve is one of the nerves deep in the brain, and it's specifically the nerve for facial sensation. It isn't the nerve that moves the muscles of your face in terms of smiling and frowning and facial expression. It does move a couple of muscles, but we'll talk about that later, but it's not the nerve for facial sensation, for facial expression. When you have trigeminal neuralgia, there are essentially two problems with the nerve. The first is that the nerve is irritable and it gets little pulses of electrical activity inside the nerve. The second problem with the nerve is that there's been some degradation of the insulation around the individual nerve fibers. So they're not working as they should, and they're allowing those little pulses of electrical activity to spread amongst other fibers in the nerve. So what is the underlying cause of trigeminal neuralgia? Why does it occur? Well, the commonest cause, but not in every case, is that the nerve is irritable due to it being compressed by a blood vessel, most often an artery. And this is a little video taken at the time of the microvascular decompression. That's actually a left trigeminal nerve that you can see, that white structure ahead of you. And sitting underneath it is an artery, and that artery is actually kinking the nerve. If you look at the surface of that nerve, it looks kinked up by that artery, and that artery is pulsing away underneath the nerve. And you can sort of imagine how this could introduce this irritability into the nerve. Now, occasionally, and this is less than 10% of the cases, the nerve is irritable for no particular identifiable reason. Sometimes people have discovered, for example, that there's some problems with the tiny little sodium channels in the cell that control nerve excitability or something else, but often there's no specific reason why the nerve is irritable in that group of patients that don't have a blood vessel there. The other common cause, though, much less so than a blood vessel, but relatively common cause, is the context of multiple sclerosis, which is a disease where the immune system is attacking the insulation that can happen around nerve fibers. And finally, sometimes there's a situation where there's something else pressing on the nerve. So this is an example of a benign tumour called a meningioma. Even in the last week, I've seen a patient with a meningioma, which is a little benign tumour pressing on the trigeminal nerve. That can certainly cause trigeminal neuralgia. Now, for the most part, the symptoms that it'll cause are pretty stereotypical. So we often talk about typical trigeminal neuralgia. If you imagine that nerve having little bursts of activity, little electrical pulses, you can imagine that it will cause pain on one side of the face, that they will be brief duration pains, that they might have a sharp or electrical kind of feeling to them. And often, as well as occurring spontaneously, they can be triggerable. So any activity in the nerve, if you start to chew or brush your teeth or something, you're going to be sending messages back through your sensory nerve in your face. And given that the insulation is frayed, for want of a better term, that's going to allow some of those impulses to cross over onto the other fibers and set things off. When you're not having a burst of activity, you'll typically have no pain. And importantly, there are medications that make nerve cells less excitable, and normally trigeminal neuralgia pain will respond to those medications if they're given in sufficient doses. Now, how does this medical therapy work? And this is the last slide on medical stuff, and then we'll get on to the surgical stuff. But drugs like carbamazepine, what they actually do is reduce the repetitive firing of nerves. So in actual fact, many or most of the medications that are used for trigeminal neuralgia are anti-epilepsy medications. And just as epilepsy consists of if you like, a storm of electrical activity in the brain that these medications dampen down, in trigeminal neuralgia, there's like a storm of electrical activity in the nerve. And again, these medications have the potential to dampen it down. So that's how they work. Now, the upside of taking these medications is that they lead to a reduction or an elimination in the bursts of electrical activity in the nerve. But the downside is that by definition, all of these medications lead to a reduction in electrical activity in all nerves, because that's what they're doing. They're making nerve cells less excitable. And for a patient, what does that mean? Well, for a patient, that can be experienced as things like slowed thinking or drowsiness or unsteadiness on your feet, or very commonly, and again, I had a patient today use this terminology without me asking for it, but feeling like a zombie is a common thing that people describe. So that's just a little bit of background as we now discuss the specifics of the surgical treatments. I would say that for the most part, we can think of the surgical treatments for trigeminal neuralgia as belonging to one of two categories. So the first is the microvascular decompression operation, which for the 90+% of patients that have a blood vessel causing their trigeminal neuralgia is the operation where we're taking away the cause of the trigeminal neuralgia. We're removing the thing that is stimulating that nerve to be irritable and have its abnormal firing. Pretty much all of the other treatments that we're going to discuss are treatments that are designed to settle that nerve down. Now, if you're not doing that with medication, how are you doing it with a surgery or a treatment like a surgery? Well, you're doing something to basically dumb that nerve down by either pushing on it, or heating it, or firing radiation beams at it, something else, and we're going to talk about those. And those treatments that are trying to settle that nerve down, they can be called ablative treatments. There's an intent to cause some form of reduction in function of the nerve. And we can do that by passing a needle up the cheek, and we call that percutaneous rhizotomy, bit of a mouthful. And when we do that, we can use a balloon, we can use something called a radio frequency probe, which we'll talk about, or we can inject a chemical. And then finally, the other option, which has something in common with the percutaneous rhizotomy, is to fire multiple radiation beams at the nerve. So let's start talking about microvascular decompression. This is the operation that can address the underlying cause. And I say can address the underlying cause because, as I mentioned before, 90+% of patients, their trigeminal neuralgia is due to a blood vessel, but there are some patients for whom that is not the cause of their trigeminal neuralgia, in which case this operation won't address the underlying cause. In this operation, we move the blood vessel off the trigeminal nerve. So in the picture at the top there, you can see a trigeminal nerve in the center, and there's another nerve that's out of focus, which is superficial, which is closer to us on the left-hand side, which is the hearing and balance nerve. But you can see that there's this blood vessel pushing up on the undersurface of the trigeminal nerve there. And when we do a microvascular decompression, what we're doing is we're mobilizing that blood vessel out of the way, and we're holding it out of the way with a little piece of Teflon. So you can see in this case that not only is there a piece of Teflon holding that blood vessel further down, but that Teflon has moved that blood vessel down so that the nerve there is no longer kinked. Now, a microvascular decompression operation is a proper neurosurgery operation, meaning that typically there's a 2 to 3 night stay in hospital. But pain relief is immediate in 85 to 90% of patients at least. So when we do a trigeminal neuralgia operation, there are a few risks. There's a risk of something really major, like having a stroke or even dying from the surgery, which is exceedingly rare, certainly less than 1 in 300 patients. There is a chance in the order of 0.5 to 1% of getting some hearing loss in the ear on that side. You could see that nerve for hearing is very close by, and it can be prone to a little bit of stretch by the operation. So what we do, and what I think is an important part of doing this procedure, is that we monitor the hearing by putting a little clicker in the ear and monitoring the brain waves and making sure that the messages are getting through. And the anaesthetist is trained, or the 2 anaesthetists that I do this procedure with regularly are trained to recognise if there's any change going on in the hearing so that we can back off and stop. And I think for a standard microvascular decompression operation, it's been a very long time since we've had a case of hearing loss, but that's one of the potential risks. There's a 1 in 100 risk of getting a leakage of brain fluid out of the nose or down the back of the throat from surgery. And if that occurs, it means that there's an opening between the inside of the head and the outside world. So it means that we have to reopen the operation and reseal off the bone at the edge of the wound there. There's also some risks associated with having an anaesthetic. And there is some risk of facial numbness. This operation does not cause facial numbness as a routine, but in the process of separating the artery off the nerve, it can be quite stuck on, and we often move the nerve around to some extent. So there can be a degree of facial numbness, which typically is mild and typically recovers after the operation. The outcomes, as I mentioned, are very good. 85 to 90% of people will be pain-free and off medication. I would say that if people have a very typical history of trigeminal neuralgia in the way that we outlined before, and they have an MRI that shows that that nerve's really being pushed by the blood vessel, that it's probably more towards the 90 to 95% chance that they'll be pain-free and off medication. 3 to 4% of patients will recur in the first year, though, after surgery, and about 1% per annum of patients will have a recurrence of their trigeminal neuralgia in the years after. So the good news is for most people that they will be pain-free for the rest of their life, but there will be a minority of people who will have a recurrence over time. So this actually shows you what the operation looks like as we move the vessel. It's the same patient as I was showing before, and this is the artery moved up and out of the way, and you can now see that artery sitting up and out of the way of the trigeminal nerve. The trigeminal nerve is sort of a little bit out of focus now because I've focused on the artery, and there's a piece of Teflon that's holding that artery well out of the way of the trigeminal nerve, which now looks very free. So I've put these three photos together as a sort of a panel showing the trigeminal initially kinked by the artery being moved up and out of the way, and then the final shot with the Teflon holding the artery out of the way. So that's microvascular decompression. Let's talk a little bit now about the other treatments for trigeminal neuralgia. So what we're going to talk about next is these treatments called the percutaneous rhizotomies. So in these treatments, what we're trying to do is take that super excitable trigeminal nerve, that irritable trigeminal nerve with its bursts of electrical activity, and we're trying to calm it down by intentionally reducing the nerve's excitability, by reducing some of the function of the nerve. And in these percutaneous rhizotomy procedures, to do that, we're passing a needle through a point. The point that the needle starts is actually on the skin on the face, just a few centimeters away from the mouth. So we make a tiny little stab incision that heals up and doesn't require a stitch or anything. And then we pass a needle up through the hole in the base of the skull where the third division of the trigeminal nerve comes out of. And that gets us all the way up to a big part of the main trunk of the nerve called the trigeminal ganglion. And then we can do something to intentionally reduce the function of the nerve, intentionally damage the nerve, for want of a better term. Now, I mentioned these three different methods for doing something to the nerve. We can compress the nerve, and we do that using a little tiny balloon that we pass up into that area. We inflate the balloon that compresses the nerve, and then after a period of time, we deflate the balloon and take it out. So when we talk about the first operation, the MVD, that's a microvascular decompression. When we talk about balloons, it's a balloon compression because we're actually trying to compress the nerve. We can also use something called a radiofrequency electrode, which is a smaller needle that we pass up to the trigeminal ganglion, and we can control the heat on the tip. There's also another method of trying to cause this intentional injury to the trigeminal nerve, which is called a glycerol rhizotomy, where a agent, glycerol, is injected that has an effective kind of scarring the nerve a little bit in its location there. I don't do the glycerol rhizotomies, but I do all of the other treatments that we're discussing today. So I'll show you, you can see there, by the way, the arrow showing what the foramen ovale, the hole in the base of the skull, looks like, that we have to navigate to. And you can see now on an X-ray in a patient who's asleep that we can actually visualize that little oval-shaped hole in the base of the skull on the X-ray. And then we can pass the needle, and you can see the second view on the right there is the view from the side. And you can see that the balloon, when we inflate it, we don't use air, we actually use contrast, which radio opaque contrast, so that we can actually see on the X-ray what we're doing. And you can see that the back of the balloon, which is to the right of the screen, is sort of narrowing in. We call that a pear shape in the balloon, and that's a good sign because that indicates we're in that little cistern cavity that has the trigeminal ganglion, and that it'll be pushing up against the edge of it. So when we think about a balloon compression procedure for trigeminal neuralgia, there's really some pros and cons, and I'm going to go through each of these so that we can think about it. So what are the pros of doing a balloon compression for trigeminal neuralgia? Well, on the pro side, I guess it's a pro, you're asleep for the procedure. Of course, you're asleep for the MVD that I mentioned before, but for the radiofrequency lesions that we do with the heating the tip of the needle, we have people awake for parts of those procedures. So the pro is you're asleep. Second is that it's very quick. It usually takes less than 30 minutes. Sometimes it even takes less than 10 minutes to do the procedure. It's very minimally invasive. There's no wound to heal. Sometimes people even can go back to work the next day, for example, if they're feeling well enough. It's very effective initially. Similar to an MVD, the initial effect is 85 to 90% pain freedom. And another important thing about this treatment that differs from the MVD is the MVD is dealing with one particular cause for trigeminal neuralgia, which is a blood vessel pushing on the nerve. And even though that's more than 90% of people with trigeminal neuralgia, it's not everybody. And this, because it's just dumbing down that irritable nerve and stopping it from being so active, it doesn't matter what the cause is of the trigeminal neuralgia, the balloon compression can work for it effectively. Now, what are the cons? Well, the most important con is that I keep mentioning we're doing something to the nerve to slow it down, to make it not work as effectively. And what's the function of this nerve? Well, the function of this nerve is to give you feeling on your face. When you touch your face, you can feel it. So what happens when we reduce its functioning? Well, you feel numbness on your face. And when you first wake up from a balloon compression, it can be quite a heavy numbness. It can actually feel a bit like you've been to the dentist or something like that when you first wake up from the procedure. A proportion of people will find the numbness bothersome. Now, when I say a proportion of people, some people, in fact, probably most people will say who've had trigeminal neuralgia and they wake up and they're pain-free, but they've got some numbness in their face, they'll say, well, I don't really care if I've got this numbness, I'd rather have this than the trigeminal neuralgia. But there's a group, and I think it's around 10% of people that we do this on, who will say, look, I'm happy not to have that trigeminal neuralgia, but I've got to say, I don't really like this feeling in my face. It does annoy me. There is another con, which is that if the numbness that we create, and bear in mind the patient's asleep, so we don't really know until they're awake, affects their cornea, the front of their eye, then we have to put drops in the eye during the day and an ointment at night until that recovers. Because if you get a bit of grit or something in your eye, you're not going to feel it to blink and tear and to get it out of your eye and protect your eye. Now, I mentioned at the start that the trigeminal nerve is a sensory nerve, not a nerve that really moves many muscles, and it doesn't move the muscles that smile and so on. So you don't get a dropped face. Someone asked that from a balloon compression. However, the chewing muscles, the heavy muscle here at the back of your jaw called the masseter and the temporalis muscle are supplied by the trigeminal nerve. And that chewing muscle often is not working for at least a couple of months after we do a balloon compression. And people notice that because they feel that their chewing feels a bit off. Sometimes they actually get a bit of even TMJ pain because their jaw is not quite in the same position, something a bit different from trigeminal neuralgia. And in my experience, that usually recovers. Another con of the balloon compression procedure, though, a very important one, is that it wears off over time. So people, when they wake up from this procedure and they have the numbness in their face, they often say, even though we've spoken about it before, is this numbness going to go away? And the answer is yes, it almost certainly will go away. But when it does go away, often the pain will start up again. Another potential disadvantage of this procedure is that many neurosurgeons are not particularly familiar with doing this because it's not in their usual bag of tricks, whereas opening the skull and doing something inside is. Now, you could argue that being familiar with other intracranial operations is not necessarily a good reason to do a very small number of microvascular decompressions. But anyway, people don't need to be familiar with this procedure in many cases. So I'll just show you, this is some data from when I went over to Canada in 2009. And it just shows you that over time, the proportion of people that we've done a balloon compression on is diminishing. And you can see that really at something between 2 and 3 years, almost half the people are no longer pain-free. Now, some of them are managing to manage with a very small dose of medication or even no medication at this point. They're not necessarily back as severe as they were at the start, but they're not pain-free. And this shows you something else, which is that the way that this procedure works is by creating numbness in your face. So numbness is not a complication for balloon compression procedures. It's the method by which the procedure works. And you can see that the ones the people who were numb are in that top curve, and the people who didn't get any numbness, they might get a bit of pain freedom for a while, but it tends to recur pretty quickly. So the discussion I like to have with patients about balloon compression is when you're choosing a balloon compression, you're actually saying, I'd rather feel this numbness in my face, this feeling maybe like a bit like I've been to the dentist, than have this horrible pain. And it's a trade-off. It's not a free ride, unfortunately. So I won't talk about radiofrequency and glycerol in any more detail because of time, but I would like to talk about the stereotactic radiosurgery, of which gamma knife is the most well-known type. And stereotactic radiosurgery has some similarities to balloon compression in that we are trying to do something to intentionally make the trigeminal nerve work not quite as well. But in this case, we are shooting hundreds of tiny radiation beams from all different directions that focus in on the nerve to give the nerve a high-dose radiation treatment. So I'll show you, this is gamma knife, which is this very well-known version of stereotactic radiosurgery. We obviously need the patient's head to be very still in order to do a gamma knife procedure. So for one method of doing that is by actually using what's called an invasive head frame. So this is a non-invasive procedure as such, but we still need the head still. So we put some local anesthetic into the scalp, and we affix that head frame. We then do an MRI and a CT that we can join together. And between myself and the radiation oncologist and the physicists, we all check the plan and make sure that we're happy with what we're going to treat. And then we bring the person into the machine. Now, you don't feel anything when the radiation is being delivered. There's no noise even. It's a quiet treatment. It usually takes, at the moment, I'd say it takes about 55 minutes or something like that to deliver the requisite dose. And then at the end of that, we simply can take the frame off the patient's head, and they have a cup of tea and they go home the same day, and it's all done. So when I talk about this procedure with patients, points that we need to talk about are that it's an outpatient procedure. You don't get admitted to hospital. You don't need to stop your blood thinners. If you're on aspirin or even on warfarin or Eliquis or the other blood thinners, you don't need to stop them. However, unlike the other two procedures that we've discussed, it doesn't work straight away. In fact, the median time to it working, kind of like what would happen to the average patient, is it would take 4 weeks from when we do it to when it's effective. It's not as numbness producing as a balloon compression is. I think a balloon is a harder hit to the nerve. This is a little bit more of a mild hit to the nerve and a little bit more of a slow burning kind of hit to the nerve rather than a one-off thing. Severe complications are extremely rare with gamma knife. And though the other issue with it is it's less effective than the other techniques. So it is actually, of the three things that I'm talking about, it is by a significant margin the one that I do least commonly. About 70 to 75% of people will get good pain relief, but if we measure it as truly completely off all your medication and pain-free, it might be 50 to 60%, so not nearly as good as the other ones. It does wear off over time, a bit like a balloon compression, maybe a little bit more slowly. As I said, the radiation has its effect a bit over time rather than a balloon, which is all at once. And a couple of graphs here just to show you. The first one is the time until satisfactory pain relief. And so you can see that, in this one, somewhere around 3 to 4 weeks, half the patients have reached the point of satisfactory pain relief. But for some patients, it can even take 3 months to get to having good pain relief. And the second curve is really important, which is I told you that only a minority of people actually do get facial sensory symptoms. By the way, sometimes it's not numbness. Sometimes it's a bit of a funny feeling, like a crawling feeling or a tingling. But the people who do get the facial sensory symptoms, maybe not surprisingly, actually have much better pain relief over time, whereas the people who don't get facial sensory symptoms have this more typical sort of drop off over time, although still not dropping off as quickly as the balloon compression patients. So my last slide, and then we'll go over to questions, and there's plenty more to talk about, is a bit of a comparison slide between the three different options. By the way, I originally made this slide for a talk for the Trigeminal Neuralgia Association, I think 10 years ago. I haven't really changed it, but I think it's true. So MVD, that's the open operation when we go through a window in the skull to get there, when we move the blood vessel out of the way. Perc rhizotomy is like the balloon compression, and radiosurgery is the radiation version of treatment. Now, what's the effectiveness? Well, it's very good for MVD and perc and balloon. It's okay to good for radiosurgery. Numbness, well, sometimes you get a bit of numbness for the MVD. Percutaneous rhizotomy or balloon, usually you get numbness. In fact, if you don't get numbness, I'm worried that you're not going to have good pain relief. Sometimes you get some numbness from the radiosurgery, but probably most people don't. Minor complications, well, they're occasional with MVD, they're occasional with a percutaneous rhizotomy. They're actually very rare with radiosurgery. Major complications are rare with a microvascular decompression. They're very rare with a percutaneous rhizotomy, and they're extremely rare with radiosurgery. Of course, we're not including numbness as a complication here when we're thinking about these complications. Recurrence, well, at least most people won't have recurred 10 to 15 years later in MVD, because most people will stay pain-free for life. With a percutaneous rhizotomy like a balloon, 2 to 5 years is something like the median time to recurrence, maybe a little bit longer with the radiosurgery. Does it work for multiple sclerosis? Well, MVD doesn't really work for multiple sclerosis. I know that people have done it for multiple sclerosis, but it's not really kind of addressing the problem for multiple sclerosis, and I think a lot of people recur pretty quickly when you try and do an MVD. Whereas the other ones, because they're acting on that final common pathway of an irritable nerve, they do work. And then in terms of the time to work, it's immediate for MVD, it's immediate for percutaneous rhizotomy, but it's an average of about 4 weeks for radiosurgery or gamma knife. So I'm going to figure out how to stop sharing my screen when my mouse comes over there. Oh, no, I've got to do this. And then I think I can hand it back to Liam. And
Ben, thank you very much. Fantastic presentation. And we've actually got quite a number of questions that are flowing in at the moment. So, but I might give you just one moment to draw breath there and just ask some of our panelists a number of questions. We'll get the panelists to turn on their video if they can, and just ensure that they're not on mute. Shane, we might start with Shane, what surgical procedure did you have, and do you consider it a success?
Hi, Liam. Hi, everyone. Yep. So the surgery I had for my trigeminal neuralgia was the MVD. I had that about in 2016. I think it was around this time in 2016, and I would consider it a very good success because I've been pain-free, medication-free since I came out of this surgical room, heading into the ICU that night. So yeah, it has been really, really good for me, really good outcome, and I think I've been very, very fortunate and lucky.
Excellent. That's a good news story, Shane. Thank you. Kath, have you had surgery?
Yeah, I had an MVD in 2012,
Okay.
and had pretty much a really similar course to Shane. So I came out into the ICU for a day and just had some observations for another day, and then was in a normal ward for about 5 days, including the ICU days, and have had no pain since 2012. And I just, yeah, like I said, like Shane said, he just considers himself very lucky, and so do I. I'm just very, very lucky that it worked for me.
And Kath, how soon after your diagnosis of trigeminal neuralgia did you opt to have your surgery done?
It was 2.5 years, so 2009, the end of 2009, and then I had 2012, around about August, I had the surgery.
Okay, and how were you managing? Were you managing using medication in that 2.5 years?
Yeah, so initially it was obviously trips to the dentist, thinking it was teeth, and getting fillings refilled and all sorts of things, and then finally getting a referral to Royal North Shore pain specialist, to Professor Peck, and just getting him sorting out some medications and finding which ones made me zombified and which ones, weren't that great, and then just sort of getting to the point where I was like, I can't keep doing this, and
Mhm.
yeah, and
Yeah.
then getting referred to a surgeon. So
Okay, thanks, Kath. Peter, have you had surgery?
I have. I've had all three that you're talking about.
Mm.
In a sense, I have a different cause to my TN. Mine was caused by a meningioma tumor growing on the nerve. So in 2009 and 10, I had actually open skull surgeries, not an MVD, but open skull surgeries to try and cut out the tumor, but it kept growing. So in 2013, after I spent 5 weeks in hospital trying to control the pain, I then had the radiostatic surgery with Dr. Jonker. It took, in my case, about 2 months for the effect to take hold. And it lasted for 2 years. I was pain-free. But then in 2015, that pesky little tumor grew again. And Dr. Jonker decided to do the balloon compression. And that's it's 7 years ago now. So I've been pain-free for 7 years. And as I tell people, although I have numbness on the right side of my face, unless I'm talking about the numbness as I am now, I don't notice it. I just forget about it. But as soon as I say someone says numb, I can feel my lips swell up and my eye go puffy. But there is no way I would swap that for the pain or the medication side effects. I know in most cases it's a last resort, but I found it very successful.
Yeah. Peter, thank you very much. Ben, a question for you. Is the balloon compression often used as a stepping stone to an MVD?
Not often, but sometimes. And in my experience, there's been a few scenarios where it's happened like that. Sometimes people have just been frightened of having a bigger operation, and so they say, I'm not ready. I don't want to have the bigger operation, but I'm in a bad way and I need to do something about it. Another situation is I've had some people who are just so severely kind of dehydrated and ketotic from not eating and drinking from their trigeminal neuralgia that they come into hospital sort of really sick. And if you tried to go straight to an MVD, it's not a great idea because they're not really optimized for a 2.5 hour general anesthetic, so you're better off doing something temporary. I've also had a couple of pregnant ladies who had bad trigeminal neuralgia where a balloon was a much better option to just deal with it then. And then the thing that used to happen in Canada, I worked in Calgary for a little while, was you'd have all these seasonal workers in oil fields and they were there on their seasonal contracts and they were like, I'm not taking 4 weeks off to get over a big operation. Just do this thing and I'm getting back and I'll deal with it in my off season when I'm not here earning money on the oil fields or whatever they were doing. So yeah, sometimes it's practicalities like that. Sometimes it's just that the pain's so bad that you've got to do something straight away, and the balloon's very quick and easy to organise. And sometimes it's people's personal preference because they're worried about having a bigger operation.
Yeah, it's really interesting, the individual situations that people are in. Just a reminder to everyone to use the Q&A function. We've got a couple of questions coming through. Jody is asking, Ben, is a percutaneous rhizotomy the same as a nerve block?
Most of the time when people use the term nerve block, in my experience, they're talking about kind of peripheral nerves or spinal nerves. They're talking, so you can do a nerve block, for example, of up here, say someone's got pain up here, you could block the nerves that supply, which is part of the trigeminal nerve that supplies the forehead with some local anesthetic. Most people don't use the term nerve block for percutaneous rhizotomy. I haven't heard that. And we don't tend to inject, when people do nerve blocks, they're usually using a combination of local anesthetic and steroid medications for spinal nerves and other nerves, whereas we're not tending to use those combination of medications for for the trigeminal nerve. It's a bit more permanent too. It lasts a lot longer than a standard nerve block.
Okay. Shane, can you just tell us about your recovery time? You had the MVD, and as Ben has said, that's a 2.5 hour operation. So you're a young fit guy. How long did it take you to recover? How long before you're back at work and doing all those things that you normally do?
Yeah. So with my surgery, I think when I came out of the surgery on my way into the ICU that same night, I kind of had probably about 10 seconds wake up from the anesthesia, and I could, even in that short duration, I could tell straight away like I didn't have any more pain. I had a bit of numbness on my face that night, but I could definitely tell the pain was gone. And I was in hospital for about 3 days, so it's about two nights. And I think it's mainly because I'm young. My balance and any issues that that would be related to the surgery, I didn't have any problems. I was walking downstairs pretty much, the next day. My balance was back very, very quickly. I was off medication very, very quickly. I think because it was Dr. Dexter that did my operation. I think I kept taking the medication, a very reduced dosage, probably for about 2 days after the procedure, and I just slowly weaned it off, and it wasn't even necessary. I think it was because of the medication, you just can't go cold turkey, so I just weaned it off very, very quickly, but low dosage, very quick. And then in terms of recovery, I just followed the advice from the neurosurgeons. Don't do any housework, lift up heavy things. But I was actually I started playing soccer again pretty much like a month and a half after the surgery, no problems. I was even able to head at the ball and do runs and tackles and stuff, no problem. So it was I recovered very, very quickly.
Excellent. That's really good to hear. And look, I resonate with your comment that you're advised not to do housework. I had a very minor operation on my finger, and my wife.
I like the fact that you said that you followed the advice of the neurosurgeon not to do housework. We like to lead by example.
Well done. Ben, Patricia's asking how many times can a balloon compression be repeated? She's had it too, with a fair bit of numbness still, but pain starting to occur.
Yeah, so the tricky thing is that, so look, you can theoretically repeat it many times, I would say, but I'm always exceedingly reticent to repeat it on somebody who still has some facial numbness left over from a previous procedure. And one of the reasons is that you can get other kinds of pain in your face from creating repeatedly too much numbness in the face. We all know sort of this idea of somebody who's had an amputation of their limb getting a pain in their limb that's not there. And if you repeatedly numb the face, you can end up with a situation where your brain is not getting the signals that it should be from the face, and it's making up sensations that can be unpleasant in the place of the sensations it should be getting. So if somebody has pain coming back, you want to be really sure that is it trigeminal neuralgia pain versus could it be some other form of nerve pain? And then if their sensation is back at basically normal or near normal, then you can consider repeating it. Look, I probably haven't done it. I've been in practice for 11 or 12 years. I probably haven't had anyone that I've done it more than 3 to 4 times, but I guess that's probably the expected thing.
And do you think that'll increase, Ben, the longer that you're in practice?
I think so. There are some people in whom it's become clear that it's not working as well for them later down the track, but they've still got typical pain. I'm thinking in particular of a few people that never had blood vessels there. They had MS and that sort of thing, MS in particular. And so some of those people have actually gone in and sectioned the nerve intracranially to try and make a more durable, cut the bottom half of the nerve basically to try and make a more durable pain response. But yeah, theoretically you can repeat it as long as you're sure that the pain that's coming back is trigeminal neuralgia. Because if the pain that's coming back is not this brief duration electrical thing, but it's more of an ache or with reduced sensation or something like that, it's probably not trigeminal neuralgia per se. Okay.
Kath, you spoke about your experience of living with pain for 2.5 years prior to your surgery. What's your recommendation for the point in illness where sufferers should consider surgery?
I think it's just, I think that's really a personal decision between you and the doctor, probably the neurosurgeon, or if you're seeing a neurologist. But also, I have heard that the longer you leave it, the worse it is. Sorry, it's not COVID. I was negative. So, sorry. I have heard the longer you leave it, the worse it is, but I'm not sure exactly. For me, I just couldn't stand it anymore. I was like, I can't keep doing the meds. I can't keep having the pain. So, yeah.
Thanks, Kath. Ben, a question for you from Kerry. She says that she had stereotactic radiosurgery 2 years ago and has been pain-free until recently. My trigeminal neuralgia and ATN flare-ups have been random. How bad should I let them get until I have the stereotactic radiosurgery again?
I think with stereotactic radiosurgery, because it doesn't last forever, with any of these ablative treatments, percutaneous rhizotomy as well, I think that it's good to spread the treatments out over as much time as you ideally can. But obviously you've got to live life in the present. So I would never encourage someone to just put up with misery so that they can spread the treatments out for a long time. I would say that when you get to the point that the medications are causing too much side effects again now, or your quality of life is diminishing, well, that's probably the time to think about repeating things. But if you've got a little bit of pain and you can manage it, take a small dose of medication and manage it, especially for like doing radiosurgery, you can't repeat it indefinitely. Like you can do it twice. There's a person that's published a series of doing it 3 times, but that's unusual. So you might want to keep it up your sleeve. Is what I'm saying for that one.
Yeah. And Ben, just another question that's come through while we're talking about radiosurgery is, what's the availability of Gamma Knife in Australia and what are the waiting times?
So there are 3 Gamma Knives. I don't know if that's technically the plural, but there are 3 Gamma Knives in Australia. There's one in Brisbane, there's one in Sydney, and there's one in Melbourne. For better or for worse, the one that's in Sydney is a private one, whereas the ones in Brisbane and Melbourne are public ones. It's not the only method of delivering radiosurgery, although it's the most, I guess, it's the most well-known. Probably the highest numbers of trigeminal neuralgia patients have been treated with Gamma Knife compared with the other technologies. I do the other technology too, which is called LINAC, and there's more options for that one around the place as well. Although I do like the Gamma Knife because the head frame means that they really don't move and that sort of thing. So, but yeah, look, so the availability is okay. The problem in New South Wales is that it's run by Genesis Cancer Care, and there's a cost associated with treatment. But I don't think that's the case in Brisbane or Melbourne. But the other one, the linear accelerator one that we do, that I do, there's not a cost associated with it. So,
have you got any indication what the cost is for the Gamma?
It's quite expensive. It's basically about $6,000 out of pocket.
Okay, for sure. That's probably a key consideration for a number of people if they're planning their treatments there. So if a patient that's living in rural or regional Australia, they'd have to travel to Sydney or Brisbane or Melbourne to have...
They'd have to travel to a major centre if they wanted to have any treatment for their trigeminal, like any surgical procedure for their trigeminal neuralgia, and they'd have to travel to one of those 3 if it was to be Gamma Knife. Yeah. So I think, for example, well, look, I don't know in Perth, for example, they've got a cyber knife, which is another radiosurgery device. I'm not sure if they do trigeminal neuralgia treatments over there, for example. But, you know, as much as anything with the focused radiation treatments with the radiosurgery, I think it's very important to have a really good conversation with the patient about it as well, because it's one of those things that sounds, you know, like at the outset, like it might be great because it's minimally invasive, but there really are some cons as well that are worth thinking about. So
yeah, for sure. Ben, we're going to draw on your Masters of Epidemiology knowledge for the next couple of questions here. One key statistic that varies with both specialists and each sufferer's personal opinion is success rate. They're going to ask, applied over what time frame is success assumed or declared, and being pain-free for 1 day, 1 week, 1 month, 1 year, 1 decade post-treatment?
Yeah, so look, the correct way to measure, if you're doing a scientific study, the correct way to measure pain relief is actually to use those survival curves. So to look at the proportion of people at each time point that is pain-free, and there are statistical methods for comparing those. The problem about talking about any one time point is that it can be quite misleading because things will be changing over time. So that's why, you know, for example, for MVD, I say, you know, it's an 85 to 90% chance of success, but there's a 3 or 4% chance of recurrence the first year and then 1% chance after that. So you can sort of imagine that, you know, once you're a couple of years out, you're probably going to stay pain-free long term, but there is a small annual risk of recurrence. That's the sort of way that I think about it.
So have you got, are you able to measure pain? I imagine pain's on a continuum and it's either not 0 or 1, but is there ways of actually measuring?
The way that we measure it in trigeminal neuralgia principally is to talk about the outcome of being pain-free and off medication. I think that's the gold standard, pain-free and off medication.
Yep.
A lot of the radiosurgery and gamma knife publications, because they don't always get people pain-free and off medication, refer to this grading system called the Barrow Neurological Institute pain grading system. And basically, they're basically saying pain that's under control, even if there are some attacks and even if there's some degree of medication being used, the patient considers it under control, and that's what they're saying is success. So I think really the gold standard is being pain-free with this procedure, not sort of those alternatives, but obviously sometimes, you know, obviously it's better to have pain that's under control than to have pain that's out of control as well. Pain-free is the gold standard.
Thanks. And just one other question about statistics here is the success rate of stereotactic radiosurgery is 66% compared to 91% for the MVD. Has this improved? Is the first question. And could the low success rate be due to the fact that the unsuccessful 34 did not actually have trigeminal neuralgia, but had some other facial neuralgia?
Yeah, and I think that's a very good point. So look, if we're talking about what's the chance that you will become pain-free from your treatment, let's say, well, they might be reasonable figures, even though we know that the MVD will be more durable in the longer term, whereas the radiosurgery will wear off. So those figures might be okay. They're not out of the ballpark of what I would consider to be right. And I do think, though, that fundamentally radiation is slightly less effective at controlling the pain than the other surgical procedures are. But I think absolutely there has been, you know, at various points a tendency to say, well, let's try surgery. If that doesn't work, we'll send you off to have some radiation or something or other like that. And then by definition, there's a slightly higher proportion of people who failed surgery who don't really have trigeminal neuralgia than if you just treated people up front, if you know what I mean. So in other words, one of the reasons that people might have an unsuccessful surgery for trigeminal neuralgia is because they don't have trigeminal neuralgia. They've got something slightly different. And so, you know, let's just say they've got postherpetic neuralgia, which is another facial pain condition that doesn't respond to a microvascular decompression. Well, then they're probably not going to respond to the radiosurgery either.
Yeah. Thanks, Ben. Now, just in the interest of time, I think we've only got time for a couple more questions. So I do apologise to those people that we haven't been able to answer the questions. We might take those on notice and try and get back to you. So if you'd like to email those, is there, Kath, is there a email address for the trigeminal neuralgias?
Yeah, there is, and we'll get that to you in just a second.
And just
I'll have
while
to.
you're doing that, 2 quick questions for Ben, just before you go. Is it easy to identify if pain is caused by a blood vessel?
Look, yes and no. What I really like to see on the MRI is that the blood vessel is actually distorting the nerve. That's pretty clear to see. Sometimes the blood vessel is just brushing up against the nerve, and that's a bit more equivocal, and I'm not always as convinced that that's really the cause of their trigeminal neuralgia when I see that.
Yeah, and you can just use a standard MRI. It doesn't have to be a...
Yeah, it has to be a high quality MRI, and usually done with 3 Tesla rather than 1.5 Tesla as a field strength.
Yeah.
And sometimes we have to repeat it. If it's not good enough when you first see it, you've got to repeat it so you can see it more accurately. And
just one final question. Does having bilateral trigeminal neuralgia change or impact the surgical options? Yeah, it does. Most of the time, bilateral trigeminal neuralgia is due to MS, but I'm not being specific. It's not always due to that, but most of the time it is. And so that's the first thing. It's unlikely someone's going to have 2 really distorted blood vessels, one on each side. It's more likely to have some other kind of problem that's causing trigeminal neuralgia. So I would say MVD is generally less likely to be an option in people with bilateral trigeminal neuralgia. And you also don't want to create that jaw weakness in the masseter at the same time on both sides. It tends to get better. So if they do have it, you're going to treat both sides. You want to stagger it, treat one side and then treat the other side later when the jaw has recovered on this side. Otherwise, if you give someone weak chewing muscles on both sides, they might wind up unable to eat and drink for a period of time. Excellent. Now, thanks, Ben. And look, we do need to wrap up at this stage. If you have a look at the chat, the email address for the Trigeminal Neuralgia Association, Kath's put that in the chat function there. So if you do have additional questions, we'll be able to take those on notice. Again, Ben, thank you very much for your time and your expertise and a really good presentation. And also to our panelists, thank you very much for your time. I'll just hand over quickly now to Kath in her capacity as President of the Trigeminal Neuralgia Association of Australia, just to wrap up proceedings.
Oh, thanks, Liam. And thanks again, Ben. It's always enlightening to hear from the experts. And it was great to see that concise treatment comparison, and also to get an honest pros and cons list, because that will help people to decide what journey they want to take with their own TN. So thanks for that. Thanks to Peter and Shane for also being part of the panel. Liam, thanks for facilitating. And thanks to you, extra big thanks to you and Tony for your vision and direction with the telehealth and webinars. Thanks to Lynn and Peter, who were involved also in the subcommittee to get the webinar up and running. Lots of hard work from everybody, and it's taking us into the future that sees us reach out and extend to our support to people that aren't in these major cities that we have support groups in. So it's going to take us on a really good journey. I'd like to make a special mention to the Cromwell Foundation for their generous contributions. We couldn't have made this leap into telehealth without them. So thanks everyone for participating, all your great questions. Yeah, definitely contact us if you have any more, and we can obviously pass them on to the experts that we know. And we'll obviously keep you informed about our next webinar via email and our new website. So thank you so much, everybody. That was wonderful.
Thank you.
Okay. That's excellent. Ben, thanks again. Really nice to meet you.
Nice to meet you too, and thanks very much, everyone.